So welcome to ATCM, the emergency medicine channel. So today we are going to discuss the topic regarding trauma in a pregnant woman. So why first we are considering this pregnancy, it is a special population. Why we want to take this special consideration while treating the pregnant woman? Why we want to we want to give the extra care for the pregnant woman. So why this is important? So first thing, why is this important? So there will be a major physiological and anatomical alterations occurs during the pregnancy and the involvement of the two patients and the woman and the fetus and obstetric specific complication during the pregnancy. It may be the uterine rupture or abruptio placenta. So the main things or there will be a physiological and the anatomical alterations and involvement of the two patients. So that is the woman and the fetus, and next one is the obstetric specific complication. So that's why we are telling this is an important. And next thing, so why we want to know the anatomical alterations? So first thing, why we want to know these anatomical alterations, or so if you want to give the appropriate and effective care to the pregnant woman in trauma, we want to know these anatomical alterations. So first thing, in the uterus, so what will happen in the uterus? So uterus, by the 12th week of gestation, uterus, it's a intrapelvic organ. So by the 12th week of gestation, it begins to rise out of the pelvis, and by 20 weeks of gestation, it is at the umbilicus level, and at 34 to 36 weeks of gestation, it is in the costal margin. So the main thing, it is the intrapelvic organ. By the 12th week of pregnancy, it starts to rises above the pelvis, and by the 20 weeks, it reaches to the umbilicus. At 32 to 36 weeks, it reaches up to the costal margin. And next one, so at the last 2 weeks of gestation, the fundus, so the fundus, it's frequently descends, the head of the fetus, it will be in the pelvic cavity, and the uterus is enlarges. So gradually the uterus size is enlarges, so it pushes the intestines so towards the cephalad side. So the intestines of the mothers, it mostly lies in the upper abdomen. So in this slide, so the important thing is, so fetal head engages in the pelvis and the uterus enlarges. So the intestines are pushed towards the cephalad. So mostly the intestines are lies in the upper abdomen. So by knowing these alterations, so what we need to remember while treating the pregnant woman in trauma. So in the blunt trauma, so as we discussed, so the most of the space which is occupied by the uterus. So the bowel is somewhat protected, but the uterus has the more vulnerability to injury. But in the penetrating trauma, so we already discussed the intestines are pushed towards the cephalad. So any penetrating injury to the upper abdomen in the late gestation, it can result in the intestinal injury. And the next, what will happen in the uterus during the first trimester, second trimester, and the third trimester. So first trimester, uterus is thick walled and the limited in size, only confined to the bone pelvis. And the second trimester, it enlarges, it comes out of the intrapelvic or location, and the small fetus which remains mobile and it is cushioned by the amniotic fluid. And by the third trimester, the uterus is enlarges and it becomes the thin walled. So in vertex presentation, the fetal head, it is usually in the pelvis, and the remainder of the fetus is exposed above the pelvic brim. So as earlier we discussed, so in the vertex presentation, so the fetal head, it is engaged in the pelvic, the remaining part, it is exposed above the pelvis. So next one is the placenta has the less elasticity. So by knowing these alterations, what we need to remember while treating the pregnant woman. So in trauma, any amniotic fluid, if it enters into the intravascular space of the mother, it following by the trauma, it leads to the amniotic fluid embolism and the disseminated intravascular coagulation. So amniotic fluid embolism and the DIC. So the pelvic fractures in late gestation. So we already discussed the majorly the head of the fetus which is engaged in the pelvis of the mother. So any pelvic fracture to the late gestation, it leads to the serious intracranial injury to the fetus. and placenta has the less elasticity. So there will be a vulnerability to the shearing force. It leads to the abruptio placenta. So next thing, what's the changes in the blood volume and the composition? So the changes in the blood volume, so plasma volume increases, WBC increases, and the serum fibrinogen, other clotting factors also increases. So and also a smaller increase in the RBC, resulting the decrease in the hematocrit value. It is a physiological anemia of the pregnancy because there will be increased plasma volume, relatively small increase in the RBC. So it's a physiological anemia of the pregnancy. So WBC also increases and the serum fibrinogen and other clotting factors are mildly elevated. So by seeing the normal laboratory investigations in pregnant women, so the hematocrit of 32 to 42% and WBC 5,000 to 12,000. So these are all the normal in the pregnant. And if you see the ABG of the pregnant woman, so pH of 7.4 to 7.45 and bicarbonate of 17 to 22 and PaCO of 25 to 30, these are all the normal in the pregnant woman. So fibrinogen, it's mildly elevated, so 400 to 450 mg per dl. So these are all the normal values in the pregnant women. So we want to consider these values while taking the normal laboratory investigations. So next one, in hemodynamics, what will happen in the cardiac output? So cardiac output, it will increases by 1 to 1.5 liters. So because of the increases in the plasma volume, increased output, it greatly influenced by the mother's position. So based on this thing, what we want to remember is, so here increasing output greatly influenced by the mother's position. So she is in the supine position, it leads to the vena cava compression, can decrease the cardiac output by the 30%. So it decreases the cardiac output by the 30% because of venous return from the lower extremities decreases. So in cardiac output, so after the 10th week of gestation, it increases by the 1 to 1.5 liters because of the increase in the plasma volume, and there will be increased output is greatly influenced by the mother's position. So in supine position, it leads to the vena cava compression. So cardiac output also decreases by the 30%, and because of reduced venous return from the lower extremities. The next one is the heart rate. So what will happen in the heart rate is it's increases 10 to 15 beats per minute from the baseline. So 10 to 15 beats per minute from the baseline in the third trimester. So what we need to remember is, you just consider this point while interpreting the tachycardic response to the hypovolemia in a pregnant patient. So next, in the blood pressure, so blood pressure will be fall 5 to 15 millimeters of mercury in both systolic and the diastolic by the second trimester, and it returns to normal at the term. So in supine position, BP will decreases it because of the compression of the vena cava. So because we want to remember the manually displace the uterus. So this is the diagrammatic representation, the manual displacement of the uterus. The next one is what will happen in the respiratory system. So respiratory system, tidal volume increases, minute ventilation increases. So the hypocapnia is a common in the pregnancy. So because of this hypocapnia is common in the pregnancy, so PSCO2 of 35 to 40 mm of Hg, it is indicates the impending respiratory failure during pregnancy, because there is a hypocapnia is the common. So if it is 35 to 40, so we are expecting the value 25 to 30 in the pregnancy, but if it is 35 to 40, it is indicating the impending respiratory failure during pregnancy. And oxygen consumption is increases during pregnancy. So that's why we want to maintain and ensure the adequate arterial oxygen when resuscitating the injured pregnant woman. The next thing, what will happen in the gastrointestinal system? So there is an increased progesterone level. So there is an increased progesterone level, and increased progesterone level, it leads to the GI system muscle. So smooth muscles will be relaxes and the GI motility will be reduces. So due to that, gastric emptying time is delayed. So due to that gastric emptying time is delayed, there will be a chances. So increased risk of aspiration in the pregnancy. So remember this, the early gastric tube decompression is needed to prevent the aspiration of the gastric contents. And next, in musculoskeletal system, what will happen? So in musculoskeletal system, during pregnancy, the pubis symphysis will be widened 4 to 8 mm. And sacroiliac joint space also increases by the 7th month of the gestation. So we just consider this point while interpreting the X-ray films of the pelvis. So consider this point, X-ray films of the pelvis and the large and engorged pelvic vessels surrounding the gravid uterus. So there will be a large and engorged pelvic vessel surrounding the gravid uterus. So any trauma, it leads to the massive retroperitoneal bleeding because of this large engorged pelvic vessels surrounding the uterus. And next thing, in the neurological system. So in neurological system, mainly the eclampsia. So eclampsia means the pre-eclampsia plus seizures. The patient is having the hypertension, seizures. So it's a late complication of the pregnancy, but it can mimics the head injury. So what we need to remember by based on this thing is we want to give expert neurological and obstetrical consultation frequently. It will helpful in differentiating the eclampsia and other causes of the seizures. So eclampsia and other causes of the seizures. So eclampsia, it's one of the complication. It can mimics as a head injury. So how to, and what's the important thing to remember is we want to give the expert neurological and obstetrical consultation frequently. It will helpful differentiating among the eclampsia and other causes of the seizures. So thank you. So in this video we are discussing regarding the what are all the anatomical and the physiological alterations in pregnancy. So in upcoming video we will discuss the what is the main mechanisms of injury and what are, how will you assess the pregnant woman, what's the treatment. Thank you.